Okay, let's talk about the recent guideline, International Society for the Study of Hypertension in Pregnancy. Okay, ISSHP International Society for Study of Hypertension Resulted in Pregnancy. First thing, what are the recommendation regarding the diagnosis of hypertension proteinuria? The blood pressure should be the blood pressure Use blood pressure should be measured using a standardized technique, including the woman position. How we will measure the blood pressure? Sitting, seat, fit, flat, and floor. Cup size larger. The mid-arm sacral pressure 30 centimeters jada. Quarter cup 5 for the diastolic BP. You use both arm at least initially. Then the BP is taken pregnancy or postpartum in any setting, and the should be measured using a device validated for use of pregnancy and preeclampsia. Hypertension should be defined as systolic blood pressure more than 140 mmHg and diastolic blood pressure is more than equal to 90 mmHg based on average at least two measurement. BP should be reported to confirm true hypertension. If hypertension is severe, systolic BP is more than 160 by 110, more than equal to 160 by 110, then repeat within 15 minutes, otherwise repeat at least 4 hours on 2 occasions in outpatient basis. The quantitative proteinuria for preeclampsia perform as a part of the work of women for suspected having preeclampsia or high risk developing it. Proteinuria should be defined as 30 milligram more than equal to 30 milligram per millimole urinary protein creatinine ratio in a spot of random urine sample, or albumin creatinine ratio is more than 80 mg per millimole and or more than 0.3 gram per day complete 24-hour urine collection, or more than 2 equal to 2 urine dipstick if confirmed testing is not available. The classification of hypertensive pregnancy should be classified according to the criteria presentable. The ISS doesn't suggest routine testing of secondary cause of hypertension in the absence of clinical. If there is there is no clinical clue for any causes of secondary hypertension, don't suggest routine testing of secondary causes of hypertension. Women with white coat hypertension, they should undertake regular home BP monitoring. The preeclampsia should not be classified as mild or severe variety in an ongoing pregnancy. An elevation in BP should not be used to make diagnosis of preeclampsia, superimposed on chronic hypertension. To the assessment of women suspected to having a preeclampsia less than 37 weeks, we recommended adding evaluation of angiogenic imbalance when available as a marker of uteroplacental dysfunction to be used in conjunction with other clinical tests. Angiogenic marker. Who will predict the preeclampsia? At minimum, women should screen for clinical risk markers, all clinical risk factor. Okay. Then at antenatal care booking, if testing is available, appropriate counseling. After appropriate counseling, women should screen at 11 to 14 weeks preterm preeclampsia risk using a combination of clinical risk factor. What are the risk factor include? Factor is BP, urinary pulsatility index, placental growth factor is available. If they have already been identified as having clinical high risk factors. The prevention of preeclampsia, all women in pregnancy, unless there is contraindication. If there is no contraindication, all women should exercise in a pregnancy to reduce the likelihood of gestational hypertension and preeclampsia. For women with the dietary intake of calcium less than 900 mg per day, at least calcium supplementation 500 mg is recommended. Women should not receive low molecular heparins, vitamin C, E, folic acid for preeclampsia prevention. This recommended led to the heparin, use of heparin for preeclampsia prevention, not for the other indication such as thromboprophylaxis in antiphospholipid antibody syndrome you can give in that situation, but not in preeclampsia. The requirement of heparin is not recommended. Then women at increased risk of preeclampsia, those are already at increased risk of preeclampsia, you should start low dose aspirin is recommended to be taken at bedtimes before 16 weeks, discontinue by 36 weeks. After multivariable screening, aspiration should be given at a dose of 150 mg night. After screening with clinical risk factor, BP and risk factor and BP, aspirin should be given at a dose of 100 to 160 mg per day. Management, place of care, women with preeclampsia or severe hypertension should be assessed, managed in hospital before carefully selected cases considered for outpatient basis. Antihypertensive therapy, the hypertension in pregnancy should be treated with antihypertensive therapy irrespective of the underlying disease. Severe hypertension in pregnancy, if BP is more than 160 by 110, more than equal to 160 by 110, require urgent antihypertensive therapy. In a monitoring setting, the target BP of hypertension should be diastolic 85 regardless of the systolic BP. The non-severe hypertension should be treated with first-line agent. Non-severe hypertension should be treated with the first-line agent oral methyl dopa, labetal, or nifedipine. Severe hypertension should be treated with first-line agent oral nifedipine, oral labetal, IV hydrogen. And the plasma volume expander is not recommended routinely. Women with preeclampsia, Maxel, women with eclampsia should receive Maxelfed to prevent recurrent seizure. Women with preeclampsia who have proteinuria, severe hypertension, neurological signs or symptoms should be received Maxel for eclamptic prevention. Women with preeclampsia who have a proteinuria and severe hypertension or hypertension with neurological signs or symptoms should be receive Maxel for eclampsia prevention. Preeclampsia with proteinuria and severe hypertension or hypertension, preeclampsia who have proteinuria and severe hypertension and hypertension with the neurological symptoms should be received. Indication for delivery evidence studies include abnormal neurological features, eclampsia, severe intractable headache, repeat visual scotoma, repeated episodes of severe hypertension despite management treatment with the class of anti-hypertensive drug, pulmonary edema, progressive thrombocytopenia, less than 50,000, transfusion of any blood product, abnormal rising of serotonin, abnormal rising of liver enzyme, hepatic dysfunction, INR more than 2, absence of DIC or warfarin, hematoma rupture, abruption with evidence of fetal compromise, non-reversing fetal or including death. A decision to be delivered should not be based upon the solely the degree of the either proteinuria or hyperuricemia. The recommendation according to guidelines is until the condition don't administer condition to assess the resolution of HLH syndrome. Postpartum care, the woman with antibiotic BP should monitor at least once on day 3-7 postpartum when it is slightly high after the birth. Then antihypertensive therapy administered antibiotics should be continued after birth. Also consideration to administer antibiotics for any hypertensive diagnosis before 6 days postpartum. Consider should be given to administer antibiotics for any hypertensive diagnosis before 6 days postpartum. The target BP diastolic is 85 as antenatally non-steroidal anti-inflammatory analgesic may be used in the preeclampsia if other analgesics are ineffective and there is no acute injury or other risk factor for it. Breastfeeding is recommended. Counseling should be provided about the risk of gestational hypertension at least 4%. There will be chances of preeclampsia future pregnancy is 15%. At 3-month postpartum, all women should be reviewed to ensure the BP and analysis laboratory have anomalies. If proteinuria or hypertension persists, then appropriate referral further investigation should be initiated. At 6-month postpartum, where possible, all women should be reviewed again, which point we suggest that 1-8-20 lead to discussion lifestyle changes. Following hypertensive pregnancy, particularly preeclampsia, counseling for the height in the health risk for the mother, particularly cardiovascular and the offspring. We recommend in the lifetime non-10-year cardiovascular risk to estimate the cardiovascular risk in the women. Annually medical review following hypertensive pregnancy is recommended 5-10 years. Following hypertensive pregnancy, all women of their offspring should adopt a healthy lifestyle changes, eating well, exercising, ideal body weight, living smoking free, MBP less than 120/80. Then the introduction, the leading cause of mortality, maternal and perinatal mortality and morbidity worldwide. More than 99% of hypertensive disorder-related maternal death occur in under-resourced country and worldwide. Under-resourced setting worldwide, while perinatal death, maternal morbidity remain major challenge for the healthcare provider. The ISSHP permit provide global health up to date. The review published study. Then methods हो गया. Recommendation diagnosis, how will diagnose BP should be measured, already I told. BP should measure in standardized technique. Movements should be in sitting position or flat on a feet flat on floor, sitting position, feet flat on floor. Large cup size, if the mid-arm circumference is more than 33 cm, correct cup 5 is the distal paper, arm is both arm has to be used initially, then the larger BP size one subsequently. Then BP measurement, already I told. BP measurement in pregnancy, measure using the standardized technique as an outside pregnancy. BP should measure both arms at least initially. Thereafter, the same arm for consistency, choosing the arm with higher BP. BP should measure the device validated for use for pregnancy only and pregnancy by extension for 6 weeks postpartum. Mercury is no longer available, while aneroid devices are used commonly, but there may be underestimated BP, so they need to be regularly calibrated. Liquid crystals is the best alternative for if unavailable. An automated device validated frequency, automated liquid crystals become manometer, liquid crystals become manometer, or automated device, another device. The liquid crystal spigmo or automated. Once BP is to be elevation in clinical setting, the clinic or office obstetric day unit or hospital inpatient, there is no evidence for preeclampsia out of office. Suppose the patient came to the clinics and office and obstetric day unit hospital inpatient, there is no evidence of preeclampsia out of office, but BP monitoring has to be done at home by 24-hour ambulatory BP monitoring. The text BP regularly in a pharmacy is advised. This will identify any element of this is the white code hypertension, kind of the diagnosis of hypertension. Ideally, thereafter, monitor changes in BP response to antihypertensive. Also, it wise to check women's home BP device against a calibrated device in the office before she begins home BP monitoring. Intermittently thereafter, ambulatory BP monitoring remains the gold standard for BP assessment, but it's less commonly used, especially in pregnancy, but the availability convenience of the woman preference. Hypertension is defined as the critical BP, systolic BP, systolic and diastolic more than 1 equal to 140, and with the systolic and diastolic BP is more than 160 by 110 is called severe hypertension, where the HCOG have a very refined hypertension outside pregnancy is 130 by 80, stage 1 40 by 90, stage 2. Okay. Hypertension should be diagnosed at least 2 reading reflect BP or visit more than 10 mm third measurement should be taken. Okay. Proteinuria using ACR, PCR, microscopy, urine analysis, screening, LCKD. Already I told the 24 protein creatine ratio more than 30 mg per 0.3 milligram per milligram, 30 milligram per millimole, to protein 0.3 gram per day, ACR 80 milligram per millimole. Although this recommended I already read. Then classification, already I classify. If you classify the hypertensive disorder of pregnancy before 20 weeks and after 20 weeks, in before 20 weeks, always suspect there will be a chronic hypertension. It can be essential hypertension, it can be a white coat essential hypertension or secondary hypertension. It can be a white coat hypertension, it can be a masked hypertension. There will be 5 criteria, 5 things, like 4 things: white coat hypertension, chronic hypertension, white coat hypertension, masked hypertension before 20 weeks. Waning hypertension, it can be essential and no other causes, no secondary causes or secondary causes. Okay, white coat hypertension is systolic BP as systolic BP is more than or equal to systolic and diastolic BP more than equal to 140 by 90 mm when measured in the office or clinic, and BP is less than 135 by 85 using home BP monitoring or ambulatory BP monitoring reading. Same, the mask hypertension is ulta. Mask hypertension is BP that is less than 140 by 90 at home, at clinic. BP is less than 140 by 90 at clinic or office, but it is more than 135 by 85, more than 135 by 85 at other time outside the clinic office. Okay. Then more than 20 weeks, already I told gestational have transient gestational hypertension, preeclampsia, chronic hypertension, supravenous preeclampsia. Hypertension, more than proteinuria, hypertension arises more than 20 gestational in the clinic. Transient gestational hypertension, that the BP is more than 140 by 90, more than equal to 140 by 90 at the clinic, which results with repeated BP reading. This is called transient. Remember this transient gestational hypertension. This has been remained here. Preeclampsia, already I told. Proteinuria, other maternal dysfunction, neurological dysfunctions, altered eclampsia, altered mental status, blindness, stroke, chrono, severe headache, fasciist visual scotoma, pulmonary edema, hematologic complete platelet count less than 1.5 thousand, 1.5 lakh, AKI 1 milligram, liver involvement. Then classification of hypertensive disorder pregnancy, already I told. If you classify the hypertensive disorder, always classify before 20 weeks and after 20 weeks. If you are classifying before 20 weeks, then remember 4 things, 3 things. One is chronic hypertension and chronic hypertension, white coat hypertension, chronic hypertension, white coat hypertension, and masked hypertension. Remember this 3 chronic, white coat, and mask. In chronic there is 2 types. It can be essential, it can be secondary causes. And the white coat hypertension, BP, the systolic BP and diastolic BP, when measured in the office or clinic, it will be more than 140, more than equal to 140 by 90. But when she measure at home BP monitoring or ambulatory BP monitoring, it will be less than 135 by 85. The mask hypertension is different. The BP was measurement at office or clinic is less than 140 by 90, and when it is measured at the outside the office or clinic, it is more than 135 by 85. This is called masked hypertension. Okay, if more than 20 weeks, I told the gestational hypertension, preeclampsia, chronic hypertension, supravenous preeclampsia. Another thing to remember, transient gestational hypertension. Transient gestational, the hypertension that was developed after 20 weeks of gestation is in the clinic, but it is resolved, okay, with the repeated PP reading. This remember. Then I told preeclampsia, all these things. The platelet count is less than 1.5 lakh here, this difference. and they previously they not including the placental abruption angiogenic imbalance factors in the diagnosis of preeclampsia. Now they added on the heading of the uteroplacental dysfunctions. Then they previously they thought ki the evidence of uteroplacental dysfunction is mostly already if those patients who have a chronic hypertension they may be develop uteroplacental dysfunction, so they didn't consider that the evidence of uteroplacental dysfunction as a superimposed preeclampsia criteria. So now but they suspecting they thinking now they included this thing, the evidence of uteroplacental dysfunction in as a diagnostic criteria for superimposed preeclampsia on a chronic hypertension disorder patient. Okay, how will diagnostic how chronic hypertension diagnosis testing and how you monitor, these are the things. All women of chronic hypertension, all women of chronic hypertension should have the following test form at fast diagnosis in pregnancy to provide a baseline reference should suspicion arise later in the pregnancy of superimposed preeclampsia. To do a baseline reference test, so that we can detect the preeclampsia, superimposed preeclampsia in later gestational age. So we have to do some tests like urine microscopy, urine protein excretion, ideally by protein creatine ratio, ACR, full blood count or platelet count, hemoglobin, serum creatine or liver enzyme AST, ALT. Additional testing can be performed. What are the additional testing? When 3 additional testing you will perform if you are suspecting if there is increasing serum creatine level or if there is increasing urine dipstick abnormal, then you go for a renal ultrasound or a electrolyte testing. Then if you are suspecting hemolysis, you go for serum LDS level and peripheral smear cystocytes for peripheral sear. Okay, if 24-hour urine collection for proteinuria or and albumin testing, serum albumin testing, protein testing for if you are suspecting nephrotic syndrome. Monitoring the frequency follow-up should be group guided by BP. Okay, hypertension, essential hypertension, and feminist hypertension, obesity, white coat hypertension. You should monitoring home BP monitoring, mask hypertension, gestational hypertension. All these things I already know. Then gestational hypertension. How does the diagnosis, testing, and monitoring? Women should undergo testing pre-eclampsia to rule out. Okay, for gestational hypertension, the diagnosis and ongoing survival, how will ongoing surveillance? Women should undergo testing for preeclampsia to rule out. First thing, you should rule out preeclampsia. Angiogenic marker, if there is availability of angiogenic marker, you could perform. If normal, then diagnosis confirm it only gestational hypertension. Fetal ultrasound should be performed to assess the fetal growth, amniotic fluid volume, umbilical artery Doppler. If FGR is detected, local national fetal surveillance guidance should be followed. Then ongoing surveillance, how you will surveil the patient. Antenatal contact should occur at least once weekly. You should call the patient. In gestational hypertension, you should call the patient at least once weekly. Come, we'll see how we'll do, what we will do, what will you do after calling the patient. You should do proteinuria testing should be performed each subsequent antenatal visit. This is the thing. The risk of adverse maternal outcome increases with actually the risk of adverse maternal outcome that will increase with earlier gestational age and or the onset of worsening of the following feature that women should be informed to report between visits. If she develops some symptoms, she has to report the visit. That is the mini pyrus model. Mini pyrus model, these are the symptoms like headache, visual disturbance, chest pain, dyspnea, vaginal bleeding with abdominal pain, systolic blood pressure increase, dipstick proteinuria, self monitoring, pulse oximetry, self monitoring. Then she has to report immediately. Then fetal ultrasound to be repeated at least monthly to assess the fetal growth, amniotic fluid volume, umbilical artery Doppler. If preeclampsia is again suspected on clinical ground, the woman should be rehabilitated for preeclampsia. Okay, then this thing has been done. Then diagnostic testing regarding angiogenic marker testing, where angiogenic marker testing available, the lack of angiogenic imbalance as assessed by normal PLGF more than 5% gestational age, normal SFLT field the no uteroplacental dysfunction. In the absence of other marker of preeclampsia, a diagnostic gestational will made rarely. Less than 1% will require delivery. Patient with the next 7 to 14 days. Also some evolve into preeclampsia at some point. Appropriate investigation should be done before pregnancy to do the underlying chronic condition. Diagnosis ongoing monitoring of gestational hypertension where angiogenic testing available. The like angiogenic is by normal PLG more than 50% gestational age, normal ratio, then absence of the marker. Okay, then angiogenic imbalance assessed by PLGF less than 50 gestational age, increases SFLT PLG ratio more than 38 by OK assay has been actively evaluated. Is evaluated for the role of making earlier diagnosis preeclampsia based on the presence of uteroplacental dysfunction, prediction, and preeclampsia. Okay. Then preeclampsia diagnosis testing and ongoing surveillance. Women should undergo comprehensive testing. What are the comprehensive testing? Preeclampsia, preeclampsia, superimposition, accompanying hypertension should undergo the same testing women with preeclampsia. She should undergo component of full virus model. Full virus model along with the earlier gestational age, symptom of chest pain, dyspnea. Here proteinuria they remove. Platelet count, oxygen saturation, serum electrolyte, uncertainty. The angiogenic markers, if available, could be performed. If there is angiogenic imbalance, the diagnostic preeclampsia would be strengthened. Fetal ultrasound should be performed to assess the fetal growth and fetal volume. If FGR is detected, is so fetal surveillance guideline should be followed. Then ongoing surveillance, the woman's preeclampsia superimposed on chronic hypertension should undergo the same surveillance when the number once confirmed significant proteinuria testing does not be needed to be repeated. Remember this thing. In preeclampsia, you already confirmed there is no need to go for repeat testing. Okay, repeat testing is not needed. Gestational age, full pyrase model has to be used in preeclampsia, mini pyrase model has to be used in chronic hypertension. Remember the full pyrase model has been used in preeclampsia, gestational hypertension, mini pyrase model. But here there is extra things is STLT, the laboratory marker is in full pyrase model. Upon administration, upon admission to delivery status, what will do? Upon admission to delivery suit, women with preeclampsia should have a platelet count on regardless of women this is performed. There is a insufficient evidence recommended evaluation with angiogenic marker where available. Fetal ultrasound should be performed once every 2 weeks to assess fetal growth, at least once every 2 weeks to assess amniotic fluid volume. Umbilical lateral Doppler recommended the less than 34 weeks fetal growth restriction Doppler evaluation with the doctor's benefits be performed if there is risk of adverse perinatal outcome. You recommended against the use of biophysical. This statement I should not understand how they are written. We recommended against the use of biophysical profile to monitor fetus risk in hypertensive pregnancy. I don't know why they are doing like this. For example, among women, okay, remember this. For example, among women with suspected preeclampsia, angiogenic imbalance has high negative predictive value in ruling out development of proteinuric preeclampsia within 7 days. Adverse mental outcome within 14 days. Delivery within preeclampsia within 14 days. When suspected preeclampsia is primarily related to hypertension but not when FGR is a prominent region. We use angiography to guide can may reduce the adverse mental outcome. Time to diagnosis preeclampsia. Identify women increases peripartum severe maternal morbidity, including postpartum hypertension, boss saving. Similar finding emergency less resource setting. Predictor of adverse outcome improved by combining angiogenic marker with other clinical routine understanding marker. The remain number of challenges for angiogenic imbalance. First challenge is the term suspected preeclampsia has used for a broad range of women. Those new worsening hypertension who undergo investigation may receive diagnosis of preeclampsia and angiogenic imbalance may add in identification of uteroplacental dysfunction. Normal testing women with one or more of the symptoms, sign characteristic of preeclampsia, FGR, cannot be diagnosed with preeclampsia. But angiogenic imbalance appear to identify those at increased progression to preeclampsia. Normal testing FGR is covered by specific guidance. Other manifestation non-specific overlap with other conditions such as migraine and ISSHP. That suspected preeclampsia used no more than 24 hours to used for no more than 24 hour to avoid confusion. Second, women with suspected preeclampsia have often studied where preeclampsia is identified defined only by gestational hypertension and proteinuria. Or women with new proteinuria did not necessarily undergo confirmed testing for proteinuria prior to enrollment. As such, many women with suspected preeclampsia would have already satisfied current ISS definition of preeclampsia. It is possible that the ability of angiography to predict delivery with the preeclampsia within 14 days may have been driven by the fact that many of the already preeclampsia ordinary angiography may lead to other respect. Understand you don't know how biology predict the adverse outcome. Okay. Challenges. The full pyrus model. Metal monitoring, I already told for 2 minutes pre-eclampsia. Metal assessment should include BP proteinuria as well component of full pyrus metal. Eclampsia, pre-eclampsia integrated estimation, pre-eclampsia integrated estimation risk score, pre-eclampsia integrated estimate risk of integrated estimate, pre-eclampsia integrated estimate of risk scoring. That is this model that is predictive of adverse maternal outcome in hypertensive pregnancy and preeclampsia, specifically when they perform at least twice weekly. Full pyrus model at least twice weekly. The adverse maternal outcome are comprised derived from the daily consensus for the maternal outcome preeclampsia. One is maternal death, neurological complication, cardiac respiratory complication, renal complication, hepatic liver. The full pyrus model include gestational age, chest pain, dyspnea, pulse oximetry, platelet count, creatinine, AST, LT. By incorporating the gestational age into model, the full pyrus model is not restricted to specific gestational age range like the prep models develop use of preeclampsia before 34 weeks. Full pyrus model does not include proteinuria once confirmed as present proteinuria testing. As once confirmed as present, proteinuria testing doesn't need to be repeated. So full pyrus. It is not known how among women with preeclampsia, the angiogenic marker performed once or serially may add to full pyrus for prediction of adverse maternal outcome or to traditional field assessment for prediction. However, there is some promising publication. Without ready access to laboratory result, Pini-Pyrus model includes systolic blood pressure, dipstick, proteinuria, parity, gestational age, symptoms, headache, visual symptoms, chest pain, dyspnea, abdominal pain with vaginal bleeding. Performance is improved with addition of pulse oximetry. An online calculator is available with ready access to laboratory result. Full Pyrus model includes gestational age, chest pain, dyspnea, pulse oximetry, platelet count, serum creatinine, STLT. While clonos reflect the central nervous system, irritability, reproducibility of clonos testing in the maternity setting and is independent predictive value for adverse outcome is uncertain. Uric acid has the high risk of adverse maternal fetal outcome, particularly when gestation is corrected, but the test was not independently predictive of adverse outcome in food parents. The fetal monitoring, although multiple methods of fetal surveillance is available, therefore no studies varies with the timing. For the 4 fetal, 4 neural adverse outcome preeclampsia, where serial FHR monitoring is a common predicts in hypertensive disease pregnancy. Serial FHR monitoring, how serially? The effect in the reduce the adverse outcome and the if any is on determined when the resource is limited, the CTG performs sexual in patient to the suspecting abdominal placenta. Other fetuses with growth restriction reduce amniotic fluid volumes, particularly risk of stillbirth, neonatal mortality, morbidity, ultrasound fetal growth. Recommended given share addition of preeclampsia, recommended care provided follow and ISO guidance for the Doppler ultrasound for the umbilical artery reduce the perinatal death after in high risk pregnancy. If less than 34 weeks of gestation, the presence of VGR additional Doppler in the doctor's penis may be beneficial as an absent reverse associated with the substantially increases of stillbirth. Neurodevelopment outcome, survivor improve when timing breath is based on the abdominal doctor's penis, short-term fetal heart rate variability, spontaneous FHR deceleration. The biological profile is not recommended as it has a falsely reassuring, it can be falsely reassuring in hypertensive and fetal growth restricted pregnancy. False positive, falsely and abnormal profile is a late finding. Very important because they are thinking prediction of preeclampsia at minimum men should be preeclampsia. Already I told. No past second test can predict the pregnancy. Then the pregnancy, high risk factor already told, preference BMI, chronic hypertension, and calcium supplementation already I told, calcium administered from 20 weeks of gestational age. Effective decreasing preeclampsia when administered 1.5 to low dose, high low risk frequency, but only patient baseline less than 900 mg. No standard method. Calcium intake of population in preeclampsia trial. Diet control, target BP 85. If it is diastolic, if it is less than 80, stop antihypertensive and decrease dose of existing antihypertensive medication. This is more than 80, start antihypertensive medication, increase dose of or existing, no changes. If systolic is considered, increase dose of existing medication, start a new antihypertensive medication to get a lesson urgent. Chip style to achieve. Management. Area of agreement. Agreement. Severe preeclampsia and the use of the term. Target location is not severe.